Hello, everyone. Welcome to the Key Populations Oral Abstract Sessions for Indigenous Communities. I'm going to be moderating today. My name is Ian. I'm with Sea to Sky Meeting Management. And I'm not going to stand on any formality here. We're going to get right into it. So if I could ask Sean Hillier to come on screen and give his presentation.
Great, thank you, Ian. Kwe, Ani, Tanzi, good afternoon, everyone. My name is Sean Hillier. I am a Mi'kmaq faculty member in the Faculty of Health at York University. I am registered with the Halapu First Nation and grew up on the southwest coast of Newfoundland. Currently a York Research Chair in Indigenous Health Policy on One Health and the Associate Director for the Center for Indigenous Knowledges and Languages. We'll be presenting today with two of my students who helped formulate this, Ryan Gladwin and Elias Shakur, and we'll be presenting an End to HIV Exceptionalism, How Indigenous Peoples Are Forgotten, a theoretical paper more so than any substantive research that we've done with Indigenous peoples, but as a part of the work that we've been doing through a number of various CAHR funded projects. I'm going to start with a quick land acknowledgement that I'm on the land known as Tekaronto that has been caretaken by the Anishinaabe Nation, the Haudenosaunee Confederacy, and the Huron-Wendat. I acknowledge the current treaty holders, the Mississaugas of the Credit First Nation. This territory is subject to the Dish with One Spoon Wampum Belt Covenant, which is an agreement to peacefully care and share for the Great Lakes region. Just as a note, you'll see here, because sometimes putting the visuals, it has a greater impact. And so here you can see the specific land that we're talking about and the Toronto Purchase of 1805 in the orange. So HIV exceptionalism. I want to provide you with a bit of context to this discussion in a theoretical paper. So historically, HIV rates and outcomes have generated discussion and enactment of exceptionalism policy. So this type of policy recognizes the exceptional needs of individuals who are living with HIV and AIDS and was primarily driven by issues related to stigma. So the history of public health responses to infectious and communicable diseases have involved mandated compulsory testing, screening, reporting of individuals to government registries, and even the use of strict quarantine protocols. And so beyond the issue of HIV in relation to these mandates, we also know for Indigenous peoples that we've been mandated through TB, through Hep C, through smallpox and other infectious diseases, through the effects of colonialization, through the effects of colonism. And so we know that this isn't just within the HIV context to which we're looking at the issues of stigma in relation to infectious diseases. But HIV exceptionalism was first enacted to protect vulnerable populations, and typically this was gay men, from public health measures that pose significant risk to individuals' rights and safety. And really, this focused around prejudice, fear, and victim blaming were the main concerns in relation to the enactment of HIV exceptionalism. So what exactly is exceptionalism? So the exceptionalist perspective recognizes the need for updated public health measures that protected the autonomy, confidentiality, the privacy, and the safety of vulnerable populations. And so the goal of HIV exceptionalism was to find a balance between the protection of individual rights and public health concerns. And we saw HIV exceptional policies being developed around the world through the 90s into the 2000s. And that many times most HIV programming in countries continue under these exceptional policies. And so these HIV specific policies are critical because the HIV is an exceptional health issue that warrants very specific types of direction because of its transmissibility, and the impacts are unlike any other disease that we had seen through this time. So this leads us to where we are today and a bit of why we came to this specific presentation. So today, the discussion and the political climate around HIV and AIDS has drastically changed from the early years of the epidemic. This change has been supported by advances both in medical treatment that have prolonged the lifespan and enhanced the quality of life for individuals who are living with HIV. However, those outcomes are focused typically within very specific populations, and within a North American context, substantially within men who have sex with men, or gay men specifically, and specifically those with a higher socioeconomic status, have really reaped the benefits of these medical treatments in the prolonged lifespan. However, for Indigenous peoples and other equity-seeking groups, we've not seen the same advantage in those health outcomes, nor very specifically for Indigenous people are we meeting those 90-90-90 targets. At the World AIDS Conference in Montreal, we'll be presenting some Ontario-specific statistics around 90-90-90 and how far behind Indigenous people are. But what we've seen as a result of these advances are that prominent scholars continue to argue that HIV exceptionalism is a relic of the past, and that there are more and more mounting calls to end exceptional HIV policies in Western developed countries. And so our whole ideal around this was to look at what the impact would be of ending exceptionalism when we have a very specific focus around these advances that benefit some, and how an end to exceptional policies may negatively impact other equity-seeking groups. So what did we do? So we used an Indigenous knowledge policy framework to critically analyze federal and provincial health policies related to HIV and to exceptionalism. These policies were gathered through open source and freedom of information requests at various levels of government, and that each policy was reviewed for Indigenous specific aspects. And so what we found out of this is that, to provide some context to the results here, is that in Canada, the healthcare needs of many Indigenous peoples falls under the jurisdiction of the federal government, be it through either direct service provision, whether it be in reserve or just off, or through the funding of provinces, territories, or directly to Indigenous organizations. However, when we look at most HIV care, it is actually administered directly through the provinces. So even those who may be living on reserve are typically still accessing labs provincially, specialists provincially, et cetera. And what we found overall was that federal and provincial governments in Canada lack any exceptional HIV or AIDS policies that are specifically targeted towards Indigenous people who are living with HIV and AIDS. While there are mention in British Columbia, Saskatchewan, provinces across the East Coast, Ontario, Quebec, the territories, and the federal level are completely absent of any discussion within those exceptional policies around the specific category of Indigenous peoples and the exceptionalism of that. And so there's no specific policy at the federal level that directs care services or funds to Indigenous communities facing an HIV epidemic that specifically seek to tackle the spread or care from from a community-centered perspective. And so what's important to note here is that there are federal exceptional policies that talk about HIV. However, they don't specifically align with Indigenous peoples. Instead, what we see is the bureaucracy kind of taking hold of the issue around HIV, funding through larger pots of funds and implementing respective programs within communities. But it really does lack cohesion and coordination across provinces with the feds. And so we also continue to see governments that refuse or are very reluctant to solve the problem with an exceptional policy. So what does this all mean? So we argue that there is a very clear need for an Indigenous created and led exceptional policies at both the federal and provincial levels to address the issue of HIV treatment and programming in order to bring us in line both with the 90-90-90 targets, as well as looking at the reduction of transmission within Indigenous peoples. We know that existing measures are not adequately dealing with the challenges Indigenous people who are living with HIV and AIDS face, including issues of stigma, privacy, confidentiality, treatment, and autonomy that continue to disproportionately impact our communities and the efforts to address the increase in new infections. The estimated HIV prevalence rate for Indigenous peoples in Canada in 2016, and these stats are being updated now, was 2 times higher than the general population, with Indigenous women accounting for 30% of new HIV cases in Canada and men accounting for 16%, with the main mode of transmission being injection drug use. And so we see that there is a disproportionate burden of new HIV infections around Indigenous peoples. And so the need for Indigenous created and led exceptional policies has never been greater. So we critique the call for an end to exceptionalism in Western countries as one based on HIV trends within gay men, and more specifically those of greater socioeconomic status across the West. Exceptional policy must take into account the fact that HIV exceptionalism hasn't actually dislodged the structures which create and maintain systems of discrimination, including settler colonialism at its core. And we critique this within our paper. And in many ways, exceptionalism has been used to extend and even deepen settler colonialism. This is pronounced when it comes to the criminalization of HIV non-disclosure and the ways that that disproportionately targets Indigenous and Black peoples in Canada. We must also be cognizant of the fact that the relationship between the Canadian state and Indigenous people is one that is already marked through exceptionalism. It's not just evident within our HIV response, but across many health outcomes. And so we need to develop an exceptional HIV policy at both the federal and provincial level that are informed and driven by Indigenous people who are living with HIV and AIDS and most affected by it, which is grounded in Indigenous knowledge systems and holistic and traditional care. And that these policies have to take into account the social determinants of health, which underline the pandemic for Indigenous peoples. And that specifically, these policies have to recognize that racism, social and colonial traumas and colonial harms, heteropatriarchy and sexism faced by Indigenous peoples continue to be a driver for the spread of HIV within our communities. And we look forward to this paper being published in the coming months. So with that, happy to take any questions. Trying to fit a very theoretical paper in 10 minutes is a hard task.
Thank you, Sean. That was great. I'm just going to look to see if there are any questions here. I'm going to give it a moment. In the meantime, I'm going to do a little bit of housekeeping while we wait for questions to come in. Candace Lice, could you check the Zoom chat, please? And Candace Norris, I am going to promote you into panelist here. And so let me double check here. I'll give another 30 seconds or so for questions. Okay, Sean, I don't think I see any questions, so thank you very much. Appreciate your presentation. And we're going to move on to our next presentation, which is Niloufar Aran. Niloufar, I don't hear you, but you're not muted.
You don't hear me?
There we go.
Oh dear, sorry about that. That was odd.
Okay, Kwe, welcome. Ninja Louisi Valerie. The name given to me 4 days after my birth was the one the eagles watch over. I've been gifted the name Nodi Wenda, which means wolf eyes, from a Dene family, and I've been gifted the name Auntie from the Torres Strait Islanders. I am Mi'kmaq, Haida, Roma, and UK Islander descent. I am a mother and a grandmother, and I'm living with HIV. I'm here today with Nilu on behalf of the Chiwos Paw team and Gatherers of Knowledge to present Wise Women Journeys, Streams of Knowledge and Rivers of Change, the tides of the Coast Salish Sea, bringing our Indigenous healthcare teachings.
Thank you, Valerie. I am just so honored to be here today and presenting with Elder Val. My name is Niloufar, which means water lily in Farsi. I'm a first-generation settler here, and I'm originally from Iran, where my ancestors and family have lived for centuries.
As we begin, we invite you to look at the smudge and see the message, Water Women Rising. We honor the ancestral traditional territories, lands, and waters across our great land from coast to coast. This is where we work, play, live, and especially learn from. We acknowledge the unceded ancestral traditional lands and waters of the Coast Salish. This is where we connect our minds, bodies, hearts, and spirit. And from where we are speaking from today, we honor the Tsleil-Waututh, the Musqueam, the Squamish, and the Coquitlam. We give thanks to our wise women, our supporters, funders, and students, and to all of you for taking this journey with us. and we have no conflicts of interest to disclose.
So it is with this background that we begin the CHIWOSPA study. CHIWOSPA is a sub-study of the Canadian HIV Women's Sexual and Reproductive Health Cohort Study. PAW stands for Positive Aboriginal Women, and it's a term gifted to us by Keisha Larkin. In British Columbia, CHIWOSPA is designed and led by Valerie Nicholson, asking the question, how do Indigenous women living with HIV in the Coast Salish territories understand their health through traditional ways of knowing? We indigenized the research process to answer this question. We used Indigenous research methods to explore how Indigenous women living with HIV on the Coast Salish territories understand their health and well-being through traditional medicines and ways of knowing. We describe our process of honoring ceremony and using water teachings to reflect on our research findings and to create meaningful and important knowledge translation tools.
These are the questions that we ask the wise women for our gatherings. How would you love to envision your healthcare? How do you use Indigenous medicine and ceremony in your health and healing? And what supported you to get through the bumps and falls of your health journey? And what message would you like to share with healthcare providers? The entire research process was Indigenized. When we got to the coding part of this journey, we found we were struggling with the Western ways and terminology. When we indigenized these words and this process, the words flowed like a gentle stream and our work was done in a good way. The word codebook and process did not work for us, and we now call that the vessels that honor the voices. Themes became our streams. Sub-themes or chapters became our creeks. Thematic analysis is honoring voices. And knowledge translation and exchange is now circular, and we call it around the fire. And the word participants, we found that the women were much more than participants. So that's why we say wise women.
So just talking a little bit more about the indigenized research approach. Indigenous research is an integral part of the CHIWOSPA project, where Indigenous women living with HIV are at the heart of the work done and the collaborative research efforts and outputs. We made sure that our team was guided with ceremony and with the leadership of elders, that our work was done with humility, respect, love, honesty, truth, wisdom, and courage. That we incorporated water and animal teachings as they are an important part of understanding our health and well-being, and used Elder Albert Marshall's two-eyed seeing approach to weave together Indigenous traditional ways of knowing and learnings from the Western world. In doing so, we held a successful and grounded two-day gathering, where the first day we worked on developing knowledge translation tools with the leadership of the wise women, and the second day we ended our session with celebration and feasting.
December 2021, the CHIWOSPA wise women gathered with our amazing elder, Elder Sheila, and the gatherers and holders of knowledge. We shared and discussed the streams of knowledge of our research, and then worked together to weave the findings into teachings. The women had the brilliant idea of developing posters of knowledge that could be shared widely. With this, they created a series of educational posters for healthcare settings serving Indigenous women living with HIV in the Fraser Salish Health Region. The 4 streams of great importance to our wise women were identified. The 4 streams are understanding that health and well-being is a journey, not only a destination. Developing meaningful care relationships and partnerships is foundational to health and healing. Integrating traditional ways of knowing, including honoring culture and traditional medicines, is essential to our healthcare, and health and well-being are connected to nature.
Each of these beautiful streams is going to be turned into a poster, and we're going to be taking you through all 4 of them. So, health and well-being is a journey. The wise women shared a deep understanding of their health. They explained that health is more than the absence of disease, but a holistic being and taking care of the mind, body, heart, and spirit. You need to be in tune with what your body needs. The women said, I know my body, I live in our body. Our bodies know a thing or two about our health. Health has a circular connection with balance and nature, where not only does nature speak and provide direction to women, but it also reminds women of the rebirth and renewal of health. Trust what I have to say, they said, and let's work together on this health journey. Meaningful relationships and community. Wise women drew strength and support in recognizing the importance of belonging to community and having meaningful relationships and staying connected with their health journey. Thinking of generations, children, and feeling a connection across generations were a significant source of support for the women. My family and sisters help keep me grounded. Inviting my family and loved ones into my care helps keep me accountable and healthy. It is so important to build meaningful and trusting relationships with my healthcare provider, they shared.
Our healing health partnerships. Healing and health can be achieved through positive and meaningful partnerships between Indigenous women and care providers. Quoting, "Nothing about us without us. We deserve equal rights. We are the ones who live with HIV, and we know our bodies." An important message from our wise women is, take time to learn about colonization and intergenerational trauma. It is exhausting to have to continue to explain this. They were also saying, we are still here, and we draw strength from our culture. We're going to grow ever stronger from it, and we're going to teach others. Health is connected with traditional medicines and ceremony. They say, please honor and support our use of traditional medicines and ceremonies as they are gifts from nature, and they are to be respected. They move us beyond a Western notion of medicines being a substance to take. And traditional medicines and ceremony are protection, both from illness and in protecting one's journey.
Honoring ceremony and cultural humility, we successfully created our posters to share the important research knowledge by, with, and for Indigenous women living with HIV. These share how the wise women would love to vision their healthcare and well-being. Wise women expressed a great deal of gratitude for the healthcare providers and created these posters to honor providers' many gifts and contributions. These will be shared widely with care providers who work with Indigenous women to help inform positive, healthy actions and to ensure that the needs and desires of these women are met.
All our relations, we Ellen, thank you. Here's our contact information if you'd like to reach out to us, and we're happy to answer any questions that you may have.
Thank you.
Thank you, Valerie and Nilüfer. I'm just looking in the chat here. So there is a question for Sean that does relate to your session. And the question was for Sean, do you think the term exceptionalism could be indigenized as outlined by Val and Nilüfer? Perhaps as change is needed to the term exceptionalism. Now I'll have to let our audience know that Sean was not able to stay. That's why he actually presented first. So he won't be able to answer that, but I don't know, Valerie or Nilüfer, if you feel qualified to comment on that.
I don't feel qualified, but I believe that we should really look at that and that word, and would happy to talk to Sean about it and bring that answer back to whoever asked it.
Okay, it was just anonymous, so we'll just leave it at that. Maybe it's a conversation for the hallways of the next CAHR conference. So I'm not seeing anything in the chat here. I'll just give it another 30 seconds or so. And so I'm going to leave it at that. I don't see any questions. So thank you both very much for that great presentation. And now I'm going to ask Stephanie to come on and give her presentation. Stephanie Conrad.
Thank you so much. I appreciate that. Sorry, there's a number of buttons to get to get everything going. Thank you so much, Ian. I would like to acknowledge and actually pass over the initial part of the presentation to my co-presenter here, Jolene. I'm very thankful that she's agreed to co-present, so I'll let her start us off and I'll conclude the rest of the presentation. Over to you, Jolene.
Good afternoon, everyone. I'm Jolene Blocka. I graduated from the University of Saskatchewan in 2007 with a bachelorate degree in nursing. I'm a mom of 3, and I've been working for Indigenous Services Canada and in the community of Big River First Nation for 15 years, most recently as nurse in charge for 5 different First Nation communities. I've been instrumental in the development and success of the Know Your Status program in Big River First Nation. I would like to acknowledge that I'm presenting from Treaty 6 territory and the homeland of the Métis. Our abstract focuses on supporting rural areas, an Indigenous community-led HIV care model, and its associated HIV cascade of care outcomes from Saskatchewan with data collected from 2018 to 2020. The Saskatchewan has had the highest incidence of HIV nationally for over a decade, with an overrepresentation among First Nations. If I can draw your attention to the map, you can see that Saskatchewan is 3 times the national rate for new HIV diagnosis. And when we look at Saskatchewan First Nation communities, they are over 6 times the national rate and still double the SASC rate. The burden of HIV began in urban centers and spread to rural and remote areas in Saskatchewan, where there was a lack of HIV care and support. Unique care models were needed to address these gaps in service in these rural areas. With the closest urban center over 100 kilometers away, an Indigenous-led nurse-based model was developed with clinical guidance from an urban infectious disease team. So before we speak to the model, we would like to acknowledge the 2 First Nations communities that have developed and continue to lead this model of care. They are Big River First Nation and the Atakakuk Cree Nation. Both are located geographically close to one another on Treaty 6 territory, 100 kilometers northwest of Prince Albert, which is the closest urban center, and about 160 kilometers north of Saskatoon. Both have very active health centers, both very strong traditional communities, open and supportive community members and leaderships. And like many First Nation communities, both of these have many members who struggle with addiction and mental health, rooted from colonization and historical trauma. For the methodology, we've reviewed existing documentation and key stakeholder engagement to describe the care model. In terms of analysis, data was extracted from an electronic medical record system for clients accessing care between 2018 and 2020, with demographics and clinical outcomes described. We define the proportion on treatment as those who have had at least 1 antiretroviral prescription in the calendar year, and we define the proportion of those virally suppressed as those clients on treatment whose last viral load within the calendar year was less than 200 copies. Our overall goal was to have clients diagnosed, seen by the ID physician, and started on treatment, to have them engaged and retained in care, keeping their viral load undetected. The HIV care model, which was initiated in 2011, was termed Know Your Status. It is a collaborative and coordinated community model, community nurse-led for case management and supported by an urban HIV care specialist team. The infectious disease team is 5 hours away in Regina. They come out to community in person every 3 months. In between those visits, they are very accessible through virtual care. Great rapport has been built over the past 11 years. So during COVID, clients were comfortable to be seen virtually by Dr. Skinner and his team. This model includes a harm reduction program, STBBI testing, HIV phlebotomy, peer support, opioid substitution therapy, as well as transportation for DOT and clinic days, also offering incentives and daily meals to help address food security. Testing days are held regularly in the community, and walk-ins are always welcome for STBBI testing. Education sessions and testing are also done a few times a year right in the high school. Services provided through this model have grown over the years, and so have the personnel to support these programs. I believe it's by having these staff members dedicated to this program that has made it so successful. Some other key factors that have been is the support and involvement from community leadership. It's community driven. It is entirely delivered in community in a culturally safe environment. It provides safe, patient-centered care. And by having all these supports embedded within the community, it provides a holistic, one-stop shop model of care.
Thank you so much, Jolene. I appreciate you presenting that. Jolene lives and breathes the Know Your Status program, so I certainly could not have done it justice. I want to also acknowledge the land from which I am presenting, which is the traditional territories of the people of Treaty 7 region in southern Alberta. And this includes the Blackfoot Confederacy, as well as the Tsuut'ina, the Stoney Nakoda Nations, and the Métis Nation. I'm going to be presenting the results, and I'll just jump right in. So for the 3 years, there were 106 clients in care within the two communities. Approximately 40% of the clients were female, which is in contrast to the national epidemiology, where we see a higher proportion males, predominantly driven through MSM risk factors. Among the clients, as you can see, women are of a younger age. We had 58% of women between the ages of 20 to 39, whereas males are certainly a bit older here. We have most or the vast majority of males that were 40 years of age or older. It is also worth noting that this younger age is that reproductive age, and certainly these clinics have encountered numerous pregnancies, which require significant and intense follow-up. The majority of the clients, or 79% of clients, had a history of a positive hepatitis C antibody result, and similarly 77 reported a history of injection drug use, and this was similar for both genders. So in this population, with the major driver of transmission being injection drug use, we have many clients who either are active participants in the Suboxone or Methadone program. Haha, that's my doorbell, sorry. Or many who continue to engage in active drug use. So while we had 106 clients over the 3-year period, there were approximately 90 clients actively in care each year. Since 2018, the proportion of clients on treatment increased from 58% to 91%. And of those on treatment, we did see a drop in the proportion of clients who were virally suppressed from 86% to 77% in 2020. We also saw an increase in the proportion of clients who had elevated viral loads. So this increased from 6% to 11%, so nearly double in 2020. So important to just note a little bit of the context. Certainly none of us have forgotten COVID-19, and COVID was a significant issue in Saskatchewan First Nations communities in 2020 and onward, leading to community lockdowns and temporary health center closures. Breaks in follow-up and lab testing as a result of COVID-19 restrictions may have had impacts in maintaining that viral transmission. However, as shown, we did not differ substantially from 2019 to 2020, signaling the good continuity of care as this model entered the pandemic in 2020. And despite the restrictions, the models resulted in a high proportion of clients receiving antiretroviral therapy with good levels of virologic suppression. And to provide a bit of a contrast or comparison, I've included here the BC estimates for the cascaded care for people who inject drugs for 2020, where they noted 59% of those on treatment were virally suppressed. The rural HIV care model provided a continuity of care through dedicated community staff who were invested in their clients and were able to prioritize and adapt programming to meet the needs. despite the challenges that the COVID-19 pandemic brought. And they were able to ultimately, in my opinion, deliver personalized care. And the outcomes of this model highlights the benefits of culturally responsive, safe, and accessible rural HIV care. I want to conclude by acknowledging the incredible and dedicated staff that make this model of care so successful, as well as the clients who engage in care and make the work so rewarding. And also would like to include and acknowledge the community leadership for their ongoing support and their bravery in acknowledging that there was a problem and working to implement solutions that we now see today. And finally, the research teams involved that include the CAHR funded Know Your Status study. And I will put shamelessly one small plug. If there's interest to hear of another rural HIV care model supporting First Nations communities, do check out another poster presentation by the team. Thank you so very much. We'll happily take any questions.
Thank you, Stephanie. I'm just looking in the question and answer box now. I don't see anything just yet for your session. There is one question here that I'm going to read out that I think is probably more for Sean, but if any of the panelists feel like they want to jump in on this, then please do so. This comment follows up on the other two comments. And Anonymous says, in a similar idea, do you have advice on indigenizing Western medical knowledge? Again, that's probably going to be fairly specific, but if anyone on the panel feels they can comment on that, that'd be great. Well, I'm going to wait for another 30 seconds or so to see if there's any questions for this first one. Here's one from David. Great presentation. And I think Stephanie's still live here. I'm going to mute her. So she's got a delivery from Prime, I think. Great presentation of a great program. Any culturally appropriate services available for mental health? This seems to be one element that is missing. So
I'm just getting my video back up. For mental health, years ago, yeah, we identified that as a need for our program. So we hired on a mental therapist that didn't come out as often as we would have liked, but I think she was there one day a week, and she only dedicated her time to our Know Your Status clients. So they got to know when she was there, and many of them would be seen by her. We're actually in the beginning stages of forming a Know Your Status building in the Big River First Nation. So our whole program will be housed in one brand new big building. So that starts here this spring. And once we have that, we are looking at full-time mental health will be part of our program. And we're excited for that.
Great, thank you, Jolene. Any other questions for Stephanie or Jolene? Okay, thank you both for your presentation. That was terrific. I'm going to move on and ask Sidim Fayette to come on. And Sidim, I'll let you introduce your co-presenters.
I think we'll start with Sharon. Thank you.
My name is Sharon Jinkerson Brass. I'm a member of Key First Nations, and I'm speaking to you from the Squamish, Tsleil-Waututh, and Musqueam People's Territory.
Candace? I think, is Candace here or did we lose her? Okay, I'll go next. My name is Sidim Fayette. I'm a PhD student at Simon Fraser University. I've been part of the Peers for Wellness project and working with Sharon, Candace, and Dr. King since 2017. I'm originally from the Middle East, and I've been living on Coast Salish territories in BC since the late 90s. And this is a picture of all of us here on the team. Sharon, did you want to introduce Dr. King?
Absolutely. Dr. King is our leader and matriarch, and she's the head of the Chemical Chair Pewasisquan Research Group.
Thank you, Sharon. Peers for Wellness is an Indigenous research project that is by, with, and for community. We are a team of Indigenous peers and allies, and we work collaboratively with community organizations. Peers for Wellness is driven by the voices of Indigenous people who identify as being cis women, trans women, two-spirit, and non-binary, and who also have lived and living experiences of HIV and Hep C. Geographically, we are situated in British Columbia, namely in the Metro Vancouver and Fraser Valley regions. Our current focus is the downtown east side of Vancouver, where we're now partners with PACE Society, which is a community-based organization that supports individuals with connection to sex work. The objectives of Peers for Wellness include introducing Indigenous-centered approaches to HIV and Hep C programming. The project launched in 2017 with a needs assessment, and the goal was to assess the need for Indigenous-centered peer navigation programs for HIV and Hep C. We heard from around 50 community members, and we learned that there is a need for comprehensive Indigenous models for care for Hep C and HIV, and not just a need for Indigenous peer navigation programs. From a community's perspective, Indigenous ways of providing care for HIV and Hep C are needed in order to respond to the negative health experiences endured by Indigenous people when seeking and using healthcare, but also to strengthen the capacity of existing Indigenous and community approaches to healing. Currently, we're in the process of developing an Indigenous program for HIV and Hep C care in the downtown east side of Vancouver. The design process is led by PACE Society and community members in partnership with our research team. And we expect to pilot this program in 2023. Next, Sharon will speak to our research approach, some of the findings from the needs assessment, and the process we used for participatory program development.
So our approach is in a good way. So all of our meetings open with an acknowledgement of spirit. So on the team, we also operate in a good way. So kindness, honesty, and generosity are part of the values that we embrace. And the participants are also invited to be a creative part of making a space for which we can do our work and work relationally. We also have gatherings as a research team to honor Grandmother Moon, to do sharing circles and wellness. We understand that, as others have said, culture is a journey. Research is a journey. It's about doing slow research and nurturing the soil that we are operating from with good medicines and Indigenous wellness practices. Do you want to take this, Sidim?
Yeah, this quote represents the community's vision for Indigenous ways of providing Hep C and HIV care. I mean, their vision was about community building, bringing together a community of physicians, elders, knowledge holders, people with lived experience, all coming together to support each other with Hep C and HIV goals. This translated in what was referred to as a one-stop shop for Hep C HIV that is Indigenous-centered and provided by community organizations and people with lived experiences.
So seeds of resilience, we have a lot of wisdom and knowledge from the women that participated in our process. These are the things, the strengths that they embraced, which is smudging, understanding that this is a journey, how strong we are, being connected to our grandmothers, to seeing everybody in the system as peers and working together in a good way. Next. These are the healthcare battles, and we heard many stories of women in our community who feel abandoned. They don't feel a part of the community. We'd heard that with a certain address, they get different services in the healthcare setting, and also that they feel invisible and not in a space where they are seen and heard adequately. Next, Sidim. So we heard all this and imagined what would it look like for all these elements to come together to create a healthcare system that's based in oneness, meaning that we have our practitioners coming together with our care recipients, that we have the cultural workers integrated, and with elder support, with ceremony and ritual and gathering, as well as education from an Indigenous lens, so that these four elements, the emotional, spiritual, intellectual, and physical, come together where we find the various harmonies and where we're encouraging ethical space to be explored, and where we can evolve together, that it's reciprocal, that we are also inviting wisdom from the women while we grow along with them and find the ways to work together as one. And one of the ways that we have thought about doing this is to have monthly gatherings and inviting everybody concerned, including practitioners, so they're not just learning intellectually about good practices with Indigenous people, but they have an opportunity for a meaningful experience and engagement. Thank you, Sidim. Next. So part of this, what I've just spoken to, is about beingness. And one of the things on our team is acknowledging the liminal space and the spiritual world in a real way. And by this, I mean, Dr. King has expressed from early on, before she was even a physician, dreaming. And so we are going from women who have looked back at our pain to women dreaming about the future and building enough connection and trust so that we can create our future together and be working as one. Because it's recognized that there's medicines in the Western tradition and in our own tradition, and finding those harmonies from a strength-based, culturally grounded, trauma-sensitive perspective.
Thank you, Sharon. Would you like to close the presentation?
Yes. in honor of all of those wise sisters, we have created a beautiful blanket of reconciliation in beginning in our process to hold the space. And we are creating a blanket with eagle feathers to honor all of our sisters and to have it be part of community celebrations like the Women's March to honor our sisters. So I would just like to ask everybody to take a moment to take in all of the knowledge keepers, our sisters, our healers, our medicine carriers, and our life givers, all my relations. Hope.
Wow, thank you, Sharon, and thank you, Sidim, for that terrific presentation. I'm going to ask if there's any questions. There is a comment in there right now. Love the Peers for Wellness logo. So you're getting some good support there. Any questions for Sidim or Sharon? Let's give it a few more seconds here. It does take time for people to type in. And if you thought of a question in the meantime for a previous presenter, everybody, well, we've lost, Sean had to go, and I know Nilüfer had to go, but don't be afraid to put it in there in the question and answer box, and the panelists is still on. We'll probably have time at the end to go over questions. Okay, I think this is for you, Sharon and Sidim. How do you privilege lived/living experience?
Thank you for that question. It's vitally important that we take the knowledge and wisdom. We know that many of the women who participate knew the answers, knew the medicines that were needed. It was not supported by the health services delivery system. And so in this way, we are, first of all, prioritizing our approach by what the women asked, which is a sense of belonging, a safe place, and wanting some culturally based resources, slowing things down so it's not just drive-by, trying to create a relationship that's a journey based on what they have prioritized.
Thank you, Sharon. I don't see any more questions, so thank you both for your presentation. And I'm going to turn to Nicole to come onto the platform and give her presentation.
All right, thank you so much, everyone. Thank you so much for attending my presentation today, titled Improvements in Art Initiation Over Time After Diagnosis Among Indigenous People Living with HIV in British Columbia, Canada. I would like to first take a moment to introduce myself and share what has led me to this work. So my name is Nicole, and I'm a research coordinator at the BC Centre for Excellence in HIV/AIDS here in Vancouver. I came to this work through a combination of my family background, where I'm a proud member of Spasm First Nation here in BC, as well as through my interest and passion for Indigenous health and community-based research. I'd also like to apologize in advance for my voice. I've had the unfortunate timing of getting COVID this week, so I'm still a little sick. I would like to first acknowledge that I'm honored and grateful to be presenting today from the ancestral, traditional, and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh First Nations. Expansion of harm reduction strategies such as supervised injection sites and government and community-based initiatives has supported the uptake of ART throughout the treatment eras. The treatment as prevention strategy has aimed to expand rapid access to ARTs to prevent transmission, and it relies on the early identification and treatment of HIV. However, previous studies have found that often Indigenous people living with HIV can experience disproportionate rates of HIV, along with delayed initiation of treatment. While these disparities emphasize significant gaps along the HIV cascade of care, it's also important to recognize that these disparities are often framed as patient-level gaps when it may actually signal to health service delivery gaps. Additionally, these disparities can be contextualized and rooted in the historical and ongoing impacts of colonization, marginalization, and dispossession of Indigenous people in Canada. The Stop HIV/AIDS Program Evaluation, aka the SHAPE study, started in 2016 with an aim to examine barriers and facilitators to HIV care. So participant recruitment took place between January 2016 and September 2018 across BC. Participants were eligible to participate in the SHAPE study if they were BC residents, had a confirmed HIV diagnosis, and were at least 19 years of age or older. Participants completed one baseline survey and 2 follow-up surveys spaced 18 months apart. An objective of the SHAPE study was to monitor key populations such as Indigenous people, people who inject drugs, women, and youth to gain a perspective on their experiences along the cascade of care. To ensure representation of Indigenous people within the SHAPE cohort, recruitment quotas were created based on the proportion of Indigenous people within the drug treatment program, which is a provincial database used to distribute ART free of charge to medically eligible residents in BC. Additionally, community-engaged research methods were used, and a SHAPE steering committee, which included community members, policymakers, peer research associates, Indigenous partners, and physicians, helped to guide the work and data collection process. So given the need in literature to include Indigenous focus analysis along the HIV cascade of care, we designed a strength-based analysis to examine longitudinal changes in time to ART initiation among Indigenous people living with HIV in British Columbia, and to also examine factors associated with delays in ART initiation. So this study used SHAPE baseline survey data, which again was collected from January 2016 to September 2018. Inclusion criteria for this analysis was limited to SHAPE participants who had indicated Indigenous identification or ancestry within the SHAPE baseline survey, and who also had a self-reported HIV diagnostic test date. The first objective of this analysis examined the median time to ART initiation after a first positive HIV diagnosis. The treatment eras were categorized as prior to 2000, 2000 to 2009, and 2010 or later. These treatment eras were chosen as they align with key care initiatives that have been initiated throughout the province, as well as the changes in ART guidelines. For example, the prior to 2000 time era represents the early heart era. The 2000 to 2009 treatment era aligns with the introduction of the treatment as prevention strategy, and the 2010 or later era coincides with BC's Stop HIV/AIDS provincial pilot program. To measure time from HIV diagnosis to ART initiation, participants' self-reported HIV diagnosis date was taken from the SHAPE baseline survey data. The ART initiation date was measured using data from the drug treatment program, where ART initiation is measured as first ART dispensation date. So based on these two measures, univariable and multivariable regression was then used to model time to ART initiation. A total of 644 people living with HIV were enrolled into SHAPE, of whom 138 self-identified as Indigenous and 125 started ART in BC. Overall, 48% were female and 53% were diagnosed with HIV in the era 2000 to 2009. And from this sample, 66% of respondents identified as First Nations, 22% identified as Métis, and 11% identified as Inuit or other. So from our analysis, we can see that the median time to ART initiation for those who were diagnosed before the year 2000 was 83 months. This then dropped to 52 months for those who were diagnosed between the years 2000 to 2009. And finally, those diagnosed from 2010 onwards had a median time to ART initiation of 1 month. So in our univariable analysis, ever having a mental health diagnosis was associated with increased time to ART initiation. However, as we can see here, this association was not retained in our multivariable model, where only HIV diagnosis in the treatment eras 2000 to 2009 and 2010 or later was associated with reduced time to ART initiation. We also did not find any associations with gender, age, health authority, education, incarceration, or history of drug use. I would also like to take a moment to note here that we had to restrict our analysis to 54 participants due to inclusion criteria restrictions, with the main limiting factors being that participants had to have both a self-reported HIV diagnosis date in the baseline survey and also a first ART dispensation date as recorded in the drug treatment program. So to conclude, despite the socio-structural challenges faced by Indigenous people with HIV, we found significant improvements in the time between diagnosis to ART initiation. These improvements may be attributed to a wide variety of factors, such as improvements in specialized HIV services, pharmacological developments, destigmatization, and increased availability and accessibility of treatment. A limitation from this analysis comes from the fact that the first positive HIV test dates were obtained from participant self-report data in the baseline survey. This introduces the potential for recall bias. Additionally, the sample size for this analysis was generally small, and the findings may not be entirely generalizable among other demographics of Indigenous people living with HIV, as Indigenous people and their identities are extremely diverse. So looking at future research in this area, previous examination of HIV cascade of care experiences have found that strategies that incorporate elements of Indigenous culture, identity, ceremony, and those that emphasize strength and resilience are often the most successful in engaging Indigenous people with HIV into care. Therefore, future research that uses a strength-based approach and examines not only barriers to care, but also really examines and looks at what are the existing facilitators and successful care strategies will help move towards a better understanding of what ideal care can look like for Indigenous people living with HIV. I would also like to take a moment to note here that an exciting upcoming study at the BCCFE called the SHARE study will aim to gain a better understanding of what these successful care strategies may look like by holding sharing circles to listen to the stories of care experiences from Indigenous people living with HIV throughout the province. Thank you everyone so much for listening today. I would also like to thank and acknowledge everyone who's contributed their time and expertise to this project, including SHAPE participants, the SHAPE steering committee, peer research associates, community partners, co-investigators and collaborators, and lastly, the BC Centre for Excellence in HIV/AIDS for their ongoing support. Thank you very much.
Thank you, Nicole. There is one question here for you, and I'll wait to see if there's a couple more. There's just one housekeeping that I want to take care of first. I'm going to ask Sidim to come back onto the platform because she just has an acknowledgement for a presenter that was part of her presentation.
Okay, I just want to take this opportunity to acknowledge Candice Norris. Candice was one of the presenters today, and she wasn't able to join us because of some Zoom issues during the conference. Candice is an amazing Indigenous woman with lived experiences of Hep C and HIV, and she has been and is instrumental to the Peers for Wellness project. I'm honored to work with her as a peer research associate and to be her friend and colleague. Candice, if you're hearing us, like, you were with us in the presentation, and I'm really sorry about the technology glitch. Thank you for the opportunity.
Thank you, Sidim. Nicole, we'll have you come back on now, and thank you for your patience. There is one question. I see two questions in here. The first question was, how was the baseline survey administered?
Yeah, for sure. It was administered through local clinics, local ASOs, as well as peer research associates help folks in person at these clinics and ASOs to complete the baseline surveys.
Okay, thank you. And one more question here. Nicole, good presentation. How much of this progress is attributed to changing guidelines and care provision across the province? And how much is related to better incorporation of Indigenous specific care / culturally informed care?
For sure, that's a great question. For sure, the pharmacological developments and the change in the guidelines throughout the treatment eras has really been a huge impactor on this change in ART initiation, and that's a huge contributing factor as well. And regarding the specific, more culturally appropriate care services that have been implemented across the province is also a really huge contributing factor. I can't name any specific ones right now, none are coming to mind, but in my background research, there's been a lot in the last few years, especially new care programs that are specifically tailored to Indigenous people and really prioritizing that culturally appropriate care and their needs have been being implemented throughout the province. And I'm hoping in the upcoming study for SHARE, we can really take a further look into those programs and how they're impacting Indigenous people with HIV.
Terrific. Thank you very much. I don't see any other questions, so I'm going to thank you for your presentation, Nicole. And I'm going to ask Candace Lice to come on. And Candace, I have your presentation ready. Do you want me to share the presentation for you and you'll just ask me to advance slides as needed?
Sure, if that's easier.
Well, do you want to try sharing or do you want me to share?
Sure, I can. Here, I'll just try sharing here.
Okay.
Oh, there we go. Did that work?
Yeah, it's working. Great.
Perfect. Great. Hello, everyone. My name is Candace Lice, and I'm a Métis woman from Fort Smith, Northwest Territories. And I've been in Yellowknife for about 13 years. And so I'm calling today from the traditional territory of the Yellowknives, Dene. And I hold a PhD in public health, and I'm the co-founder and executive director of Foxy and Smash. So I'm here today to talk about relational approaches to HIV prevention, which are our arts and land-based approaches to building healthy relationships among Northern and Indigenous youth in the Northwest Territories. So there's many challenges that Northern youth face, and I'll only briefly touch on these. But the important parts are that there's a lot of strengths-based approaches to healthy relationships, and these can hold potential for advancing sexual health and in turn, HIV prevention with Northern and Indigenous adolescents. So I'm speaking today about the Northwest Territories, so that's the middle territory there. We have about 41,000 people across a very large landmass and one of the youngest populations in Canada. So Northern youth often experience many mental health challenges, and any social and health disparities of youth in the North should be contextualized within a history of residential schools and larger contexts of income disparities and limited social and health resources in Canada's North. Despite these concerns, there's been a scarcity of culturally, age, and gender-tailored sexual and mental health programming by and for Northern and Indigenous youth so far. So I'm here today to talk about Foxy and Smash. The ultimate goal of Foxy and Smash is stronger connection with the self, with others, and with the community. And we offer annual peer leader retreats at a fly-in lodge for youth aged 12 to 19. It's held at a lodge that's disconnected from the internet and on the land. The retreats include land-based learning, Indigenous teachings, and arts-based methods. And we use arts-based methods to reach youth and address sexual health and mental health, trauma, sexuality, healthy relationships, and to teach coping skills and engage inner resiliency in our participants. We use the arts very broadly defined. This can be anything from drama, photography, digital storytelling, traditional drumming, beading, Inuit and Dene games, painting, music, dance, yoga, rattle making, and the visual art of body mapping. In this study, we had 310 retreat participants. About 80% were Indigenous and 62% were young women. And we did post-retreat focus groups with all of our participants and thematic analysis. So our retreats are 9 days out on the land. Over the last 10 years, we've engaged actually over 7,500 youth, and we've trained 475 peer leaders through our peer leader retreats. So we have both Foxy programming, which is for young women and gender diverse and non-binary youth, as well as SMASH, which is strengths, masculinities, and sexual health, and has a focus on masculinity in the programming. We find that the arts are very accessible You can engage with them without being an artist. And they also allow for bringing in cultural factors, and they're easily absorbable for youth. So we found a lot of success among using the arts in our programming. So in talking about this particular study, there was 6 salient themes that emerged from the data on healthy relationships. These included learning to identify healthy and unhealthy relationships, reflecting on one's role in perpetuating abusive practices in dating relationships alongside a commitment to change, new insights of being in an unhealthy relationship together with options for leaving that relationship, developing communication skills, social and emotional support resources, and learning about healthy relationships from peer leader role modeling, including intimate relationships and motherhood. So I'll elaborate briefly on each of these using participant quotes from our research. So the first theme, learning to identify healthy and unhealthy relationships. Both Foxy and Smash participants spoke about how to identify healthy and unhealthy relationships, including recognizing and setting boundaries and supporting youth to make the best decisions for themselves. These are all core components of Foxy and Smash programming that are woven throughout our activities that we do and modeled whenever possible by our staff. The second theme for some participants is about reflecting on one's role in perpetuating abusive practices within dating relationships. Both Foxy and Smash participants reflected on how they learned about how it is not okay to perpetuate abusive practices in dating relationships alongside a commitment to change. These responses were somewhat gendered. Young men talked more about learning that it was not okay to force someone sexually. And when it came to physical violence, both Foxy and Smash participants reflected on learning that it's not okay to perpetuate. While young men tended to speak more about this directly, young women spoke more about awareness of their feelings and strategies to calm down, as well as in, for example, the top right quote, the possible dangers in hitting a partner. A third theme from our research was that being in an unhealthy relationship and the options for leaving for participants. So Foxy participants in particular spoke about gaining new insights into being in an unhealthy relationship along with their options for leaving. They spoke about feeling more confident and also shared how they learned about healthy boundaries and how to leave unhealthy relationships. For instance, one participant felt a sense of empowerment after the retreat and said about her partner, "If he calls me something, I got boundaries and I can tell him not to call me that." A fourth theme was the development of and desire to use new skills in communication with partners. One participant said, "We learned about communication and standing up for yourself and following your intuition." Peer leader retreat programming at Foxy and Smash always centers around the notion that if something doesn't feel right, it probably isn't, and then recognizing and honoring that awareness. A fifth theme was participants recognizing the social and emotional support resources that they have or that they seek. These resources are both internal within themselves and external. That is within their friend groups, other programs and organizations, and within their broader communities. Foxy and Smash participants are supported to plan a future community engagement project when they're at the retreats, and then it's delivered when they return to their home communities after the retreat. One participant spoke about their project and how they hope to help others in their community. They said, "I feel great about my community project. It's about unhealthy relationships, and I really think people need to know more about that." And a final theme was learning about healthy relationships from role modeling. There were 2 ways in which learning about healthy relationships from role modeling was discussed. In relation to peer leaders modeling healthy relationships with each other, and a facilitator who brought her baby and modeled intimate relationships and motherhood. This suggests that visualizing enactments of healthy relationships can be an important aspect of learning, and this too is a strengths-based approach. So relationality is central to Indigenous ways of knowing, and it includes interactions between people with nature and the land, as well as connections between physical, mental, emotional, and spiritual well-being. And land-based learning holds the potential to foster sexual health and create enabling HIV prevention environments with Northern and Indigenous youth. Just have few more pictures here. And if you'd like to hear more about our programming, feel free to reach out in any of these ways. Thank you.
Terrific. Thank you, Candace. I'm just looking in the question and answer here to see if there's any questions. I don't see any right now. I'm just going to open up the floor to any of the panelists while we're waiting, Candace, see if there's any questions, if there's anyone else that wanted to come back on and had some further thoughts on any of these questions or anything that's come up watching somebody else's presentation. And Candace, I see a question here for you. Great programs. I love the focus on healthy relationship versus just risk. I'm curious, is pleasure also incorporated in the training?
Yeah, absolutely. Pleasure is one of the core components of our programming.
Okay, thank you. Okay, well, I'm going to leave it at that. So I want to thank all our presenters today. That was terrific, and the audience for staying with us. And on day 3 of the conference,